compassionate health care for your entire family, from virtual visits to office appointments. We're committed to providing the best care. We accept all insurances and we provide monthly wellness plans. Let's start your family journey to a healthier, happier life. Schedule your appointment today. And remember, true wealth begins with good health. All right, everyone. Good evening, and welcome to another episode of Telehealth Tuesday, your go-to podcast for insights on modern healthcare and wellness solutions. I'm Dr. Michael Bookhardt, your host, and today we have a very special episode lined up just for you. So I want to let you know that Telehealth Tuesday can be viewed on multiple platforms, including our YouTube channel, Dr. B TV, that's the word doctor spelled out DOCTOR. The letter B is in boy, TV, on YouTube and also on Instagram and Facebook under Michael Bookhardt Facebook page, and also Heart of Music Instagram. Please follow, like, share, and subscribe to help this amazing program, help support this amazing program. So I know that we're running a little bit late here, folks, and we apologize for that, but it is live, or I say live TV, but this is a live podcast, and so we had a few technical difficulties, and so I'm not even going to go through the bio. I want our next guest to tell you all about himself, Dr. Donald Baker, who's become a friend of mine and colleague, and worked with him for several years in the hospital system. So without further ado, ladies and gentlemen, I'd like to welcome my good friend and colleague, orthopedic surgeon, Dr. Donald Baker.
Hey, man, how's it going?
All right. We got a round of applause. Yeah, how's it going? How are you feeling tonight?
Feeling good, man.
Awesome.
Just got home.
I just got home. Let me just put this up here. We're going to put this graphic right now with orthopedic surgeon, Dr. Baker. Let me put that. Can you see that on your end in the comment? Let me see. Okay, there we go.
Yeah, I think so. Yeah.
You see that? Awesome. Well, that sounds like you had a long day, man. You had some surgeries today.
Yeah, I did. So I did. I clinic this morning and surgery this afternoon. So
awesome. How'd that go? What type of cases did you do today?
I did 2 knee replacements, hip replacement, and then fixed a wrist fracture.
Man, you're a busy guy.
Busy today.
Yeah. So tell us all about. I didn't get a chance. I didn't want to go through the read and all that stuff because I know we were already running a little bit late. But we'd love for you to tell us all about yourself and what you do and how much training you've had to go through and what you specialize in. Tell us all about Donald Baker.
All right, man. Well, I'm originally from Alabama. I went to college at a place called Sanford University, which is a Baptist college, private Baptist college in Birmingham. And then I went to medical school at UAB for 4 years of medical school, and then I did a residency in Jackson, Mississippi at the University of Mississippi Medical Center for 5 years. And then I've been in practice since I finished there in 2012.
Awesome. So how do you feel? I mean, do you love it just as much as when you were bright-eyed and bushy-tailed out of residency?
Yeah, man. I think I wouldn't have picked anything different. I think what I do is definitely interesting, and I just can't really think of. I think there's nothing else I think I would rather do for sure, especially in medicine. So,
man, that's amazing. I'm letting everyone know if this is your first time being a part of Telehealth Tuesday, you definitely don't want to miss this. We're here live with Dr. Donald Baker, orthopedic surgeon here in Jackson, Mississippi. He's telling us about himself and his practice. And look, this is the place, as we say, each and every Tuesday, to come on, ask your questions, anything that you want to know related to any bone or joint in the body. This is the place to be. Dr. Baker operates on, I get nearly everything. Is there a bone that you don't operate on?
Well, I don't. Like I said, I'm a general orthopedic surgeon, so we do a little bit of everything. I don't do really much foot and ankle stuff. So other than that, hips, knees, shoulder, we do all that kind of stuff.
So when it comes to total joints, total hips and knees,
hip and knees probably half my operative practice.
Okay. So when there are the surgeons that more so specialize in total joint, What's the difference in like when you said general orthopedic surgeon or
So,
those guys that only do knees or hips?
well, so the guys that only do hips and knees probably did another year fellowship in hip and knee replacement, and so generally those guys only do hip and knee replacements. Now there are some situations where guys who did a hip and knee fellowship will still do some other things. I think it just kind of depends on the practice. The bigger practice here in Jackson, those guys are they're pretty self-specialized, so they don't really dabble in anything else. But some of the smaller groups, guys still do other things.
Gotcha, gotcha. And just for just with our audience, because we have audiences from all over and different people who watch the show that are certainly not in the medical field.
Sure.
So if you could just maybe explain to our audience what an orthopedic surgeon is, a general orthopedic surgeon, like a day in the life.
Yeah, so I mean, general orthopedics is just that we see, multiple bone and joint problems, right? So anything from shoulder, elbow, wrist, hand, hip, knee, and even ankle stuff. Even if I don't do a lot of ankle surgery, we still see those problems. So most of the time we see patients who get deferred, either usually get to us in a couple ways. Most commonly through the ER. Somebody has an injury. They see in the emergency department, and they see us. They send them to us, and we see them in clinic to evaluate them. And then sometimes primary care doctors will see somebody with kind of more arthritic kind of things, and they wind up in our office. So,
Awesome. What would you say is maybe like the most complex surgery that you do?
oh man, I think the most complex thing or surgery I do is probably a revision knee replacements. So that involves somebody who's already had a knee replacement initially, and then having to do the revision. It requires taking out something that's already in there, and then doing a restoration procedure. So that's
Mm,
probably the most complex thing that that I do. So.
mm. And how often does that occur? Like, do you have to be involved in that? Quite
I
often.
feel like, I mean, I do, maybe one or two of those a month, not every day kind of thing. The guys that do hip and knee replacements probably do more revisions than I do. The guys that only do that kind of thing tend to do those more often. But revision is definitely not as common as primary hip and knee as, having it done the first time. So even guys who are, really busy maybe do one a week. They aren't doing, most guys are not doing uh, three or four a day unless they're at some, big referral center. UMC, one of those kind of places. Sometimes they'll do more than that, but not
Gotcha,
terribly common.
gotcha, gotcha. Man, that's interesting. I think I might have told you when I met you or something. I love surgery, man.
Yeah.
I actually wanted to be a general surgeon, man.
There you go.
Yeah.
Yeah.
But yeah, I think it's just amazing. But whenever as a surgical tech, whenever we would do the ortho cases, man, I was like, there was so many steps in there, and the different trials and
Yeah.
all that kind of stuff, man.
There's definitely a lot of, we definitely have a lot more toys and a lot more stuff to use than most,
Yeah,
general surgery, they don't have as many, there's not many things to open in general surgery cases there are in ours. So,
yeah.
I think
So
that's like sometimes the techs don't like to be in there. It's too many things to open. So,
yeah, but yeah, because yeah, right. You have this tray and this
yeah.
mail stand and this tray and yeah.
Yeah.
You do you there was a lot of ortho guys are always playing rock music, man. You play rock music in the war?
Sometimes, man, I think generally I let whoever my tech is pick what they want to listen to because that tends to make them happier. So I think.
Oh, really? Yeah, that's awesome, man. That's awesome. So tell us, here in Jackson, Mississippi, you've got so many people that unfortunately are suffering from chronic pain and morbid obesity, and they're putting all this weight on, and diabetics, and so they're putting all this weight on their joints, and sometimes I know they most likely might even have infected joints. Uh, like, what I mean, how does that cause complication, on their surgery, like with somebody who's morbidly obese, diabetic, and they're not eat, how does that play a factor in their surgery?
Well, I think it definitely increases the risk of complications, right? If you look at people who are diabetic, especially people who have poorly controlled diabetes, whose A1C is over 7, those people, they don't do as well. They're increased risk of infection, and it's the main thing we worry about, just because they don't heal as well, right? I mean, their blood sugars high all the time. The wound doesn't heal as well. They tend to get, they tend to drain longer. They tend to really increase the risk of getting infected. So that's the main issue I think with that. And diabetes is like I said, a big risk factor, but it just weight itself. People who are overweight still have an increased risk for things like wound problems and those kind of things. So being heavy in of itself, even if you're not diabetic, still increase your risk of having a complication from having an orthopedic procedure.
Mm. Well, I know that you trained at UAB. Would you say that you see a lot more issues with diet, with morbid obesity and diabetes here in Mississippi when compared to other places that you've either traveled or trained at?
I mean, Mississippi definitely has a problem, more so than some other places. I mean, I don't know that Alabama's too far behind. I think
Well, yeah.
yeah. So it's definitely, I think Alabama, Mississippi, all the kind of Rust Belt states. I think that's a kind of tends to be a problem. We all like to eat fried food and those kind of things, and I think that doesn't help us too much. So
Yeah, yeah, and I went to undergrad in Huntsville, Alabama.
yeah,
So yeah,
yeah,
not too far from
not too far
UAB.
from Alabama.
Yeah, definitely. What would you say is your favorite surgery to perform?
I like doing hip and knee replacements probably as much as anything. I think I do them robotically, which I think is something
Mm,
that hasn't been around too long. So it just makes it a lot more precise, and I think it definitely makes it enjoyable to do. I think having some of the computer programming in when you do the case is makes it definitely more interesting. I think a lot more precise too. So
so yeah, now and I've been away from the operating room for several years, many years. So I remember when the Da Vinci was coming out, the robot for y'all, for
really,
those who are listening, the Da Vinci robot, and they were using it for a lot of urological surgeries, prostate surgery, and OBGYN. They were getting used to, they were getting interested in it to do gynecological surgery.
yeah.
But man, I didn't know any orthopedic surgeons that were using the robot.
Yeah. So the Da Vinci is strictly a robot that's used for general surgery, right? General surgery, GYN surgery, urology.
Yeah.
That's Da Vinci. So um, a lot of the implant companies, when I say implant companies, I mean the people who make hip and knee replacements. They all came out with their version of a robot, right? I use
Mm,
one called the Mako, which is a Stryker. The company I use for their hip and knee replacements, a Stryker product, and so it's different than Da Vinci in that it's not. When you do Da Vinci, it's got a bunch of arms. Most of them, some of them four, some of them five arms, and you kind of use that to do abdominal kind of surgery.
mm,
Almost all the robots are single arm, and it's an arm assisted device, right? So you have either if you're doing a knee replacement, the robot will hold. In my case, the Mako robot will hold the saw, and so before somebody has surgery, they have a CT scan, and the robot, the computer builds a 3-dimensional model of their knee. Okay, and so we use the computer to plan their knee replacement, to size it, to balance it, to make sure it's going to, move like we want it to. And then we bring in the machine, and after we get the joint open, the machine helps you make the cuts that we make in a knee replacement. So it just makes it much more precise than they started out once upon a time using jigs, where you just kind of hold the jig up there and make
mhm.
it kind of while, yeah. And then that kind of transitioned to some more navigation, where you had a computer that helps you align the joint. Now it's almost in town, almost everybody uses some kind of robot, whatever their proprietary one is for whatever implant they're using. So
Wow. So this and it's like a single arm, so it'll actually will it actually make the, like, instead of you holding that.
yeah, so like for a hip replacement, for instance, right? So a hip, when you're replacing the socket, you use a reamer to kind of make the socket bigger so that you can put a cup in,
Mm,
and the robot actually holds the reamer in position that you want it to be in, and you squeeze the trigger and it reams. So it makes the acetabular component where you want it to be. So like I said, use a CT scan beforehand, which gives you a 3-dimensional model of their hip, and so you can tell them, tell the computer when you're planning, I want to put this implant right here, and I want it to be this deep, and I want it to be this size, and it helps you do that. So
yeah, that's amazing.
pretty amazing.
So you probably wouldn't go back to the olden days now that you've had the robot.
I mean, it's hard to change. I mean, I think it's so much more precise than. than doing it by hand. I mean, it's just things you don't think about. When you're doing it by hand, things how the patient's sitting on the table, all those kind of things affect what you see. And because what your goal is to put the cup or the socket in a certain position because that decrease your risk of dislocation. It helps your leg length be better. All those things. And so if you're doing it by hand, you kind of have to. You're just kind of guessing, honestly. You use some cues about what the hip looks like to help you guide where you're going to put it, but I mean, the robot is incredibly precise, right? I mean, it's based on a three-dimensional CT scan. So, I mean, you tell it you want to put it there, it puts it there. So, which is
Wow.
awesome.
So, could you maybe help educate our audience on like what is, of course, us in medical field,
Yeah.
we talk about osteoarthritis, bone on bone, but could you maybe kind of paint a picture for our audience, like what happens, what does it look like, or what does it mean to be bone on bone?
Yeah, so I think that's a great question. So when you look at an X-ray, so let's just talk about the knee. It's kind of easier to think about. So when you take a picture of somebody's knee whose knee is normal, right? So you have thigh bone, which is your femur, and your shin bone, which is your tibia, right? When you take a picture of the joint, it looks like there's space in between the bones. Okay, the cartilage, which is the cushion in your knee, it's made up almost all of water, right? So when you take an X-ray of that it looks like space, right? So your cushion shows up as space, right? It looks like the bones don't touch, right? They do, but it's just the cushion's there. And so as the cushion wears away, which is what osteoarthritis is, just kind of what we think about as wear and tear arthritis, that space goes away until it looks like on your X-ray the bones touch, and that's bone on bone arthritis, which is kind of something most people have heard of. And that's end stage arthritis, and the treatment for end stage arthritis is replacement, arthroplasty. So
Like so, because I know my mom has suffered with some chronic pain issues and
yeah,
back and hips and knees and so what would you say at what point a person now that they have the bone on bone osteoarthritis, at what point do you think a person has just no other choice, like whether injections or
yeah,
anti-inflammatory, like where they now have to go to the knee replacement? Like what kind of
yeah.
symptoms
So
are they seeing for?
So I tell people, I give everybody the same spiel. I say, luckily what I do, knee arthritis is, it's not cancer. It's not going to kill you, right? So basically, I tell people I would have my joint replaced when it gets to the point where it hurts every day. I can't do the things I want to do because it hurts, and we're not making any better with other things, right? Other things we try for arthritis treatment would be simple things. Most people who come to see us have already tried taking Tylenol over the counter or taking ibuprofen or one of those kind of things. And so, initially we treat those people with, some kind of conservative care. So we'll try prescription anti-inflammatory. I mean, everybody's heard of like meloxicam, Mobic. I mean, all those kind of things. There are hundreds of different ones that you can try. And then if those things aren't effective, a lot of times physical therapy can be effective. I know people want to say, oh, that's not going to help me. But I mean, it's been shown that, when your knee gets arthritic, your leg gets weaker, and the weakness in the leg, if you rectify that with therapy, it can increase your knee pain and it can prolong your time before you have to have a knee replacement. If those things aren't effective, a lot of times we'll do steroid injections, right? So I tell people steroid injection is not going to make their knee arthritis go away, but it's just
Right.
it's a pain relieving injection, right? It's an anti-inflammatory. It's like taking a bunch of Advil and putting them into the joint, right? And that can be pain relieving. And people will do that. We try to make them wait. Nowadays every 4 months because inherently the steroid's not great for the cartilage you have in there. So we try to get people to spread them out as much as possible.
Hmm.
And then people even do some other kind. We used to do something called viscose supplementation, which people rooster shots and gel
Oh,
shots, all those kind of things. Yeah. So once upon a time, let's say when I first got started about 10 years ago, we did that all the time, and it was very popular treatment. But new studies have shown it's not super effective. So most insurance companies don't want to pay for it anymore. So it's not as popular as it once was. People will inject PRP, which is platelet-rich plasma, which means you draw your blood out. And you have these things called platelets, which help your blood clot, and they have some factors in them that they think can help with joint pain. So we'll draw that out, spin it down, inject it in the knee. That's almost never covered by insurance, but some people will pay for those kind of things. But of all those things, we tried all those things. I can't do what I want to do. I can't walk around the grocery store like I want to. I can't play with my grandkids. And I think if you have a bad looking knee replacements are a really good option.
absolutely. Well, we've got our first question here from the audience, and this happens to be my dear mother.
Oh yeah.
Is there? She says, is there anything that can be done to avoid the need for knee surgery later in life?
Yeah, I mean, the best thing you can do that's been shown repeatedly is to be active, right? Being active helps more than anything. The more your joint gets nourishment from, yeah, the joint gets nourishment from. So like, So the cartilage itself, there's no blood flow to the cartilage. Okay, so those cartilage cells all get nourishment from fluid in the knee, right? So when you move and compress the joint, fluid gets into the knee, and that gets into the cells, and that's how it gets its nourishment, right? So moving has been shown to be incredibly helpful in delaying the need for surgery, right? So the best thing you can do is to be active, and really control your weight. Those two things. The more you weigh, the more pressure you put on your joints. So being a healthy weight and being active are two of the best things you can do to prevent your knee or hip or any other joint from wearing out as you get older. I wish you could tell you there's some magic bullet, something you could take, but we don't have that yet. So.
Man, I'm telling you, man, Baker, I've told my mother this over and over, but I'm glad that she's hearing it from the surgeon. And I will say, in fairness, she is going to see a very good physical therapist who's also a friend of mine. And
Yeah.
shout out to Dr. Sharman Robinson.
Okay.
So yeah, she is. And my mother said that she felt better today. So you hear that, Mom? She's even got one of these. Well, I'll tell you, you can't see, but she's got one of those kind of little cycling machines.
Yeah. Put
Yeah,
on
when you
yeah.
sit back and kind of So you recommend that for
I
hip?
mean, anything you can do to move is good for you. Right? That cycling motion is great. I mean, bikes, elliptical machine, those kind of things are awesome. Something low impact. I mean, some people, they're like, I hurt too bad, I can't walk, I can't run, those kind of things. But that kind of stuff, that platform bike is great.
Awesome. Jasmine Briscoe. So another friend of mine here. She's an amazing massage therapist, and
Yeah.
also, Jasmine. She says, "Would you recommend massage therapy?" I look, Doc. I always know. Actually, we had Jasmine on. Was that last week? Yeah,
Okay, cool.
been on twice. We had her. I don't know if you know Dr. North,
I do.
plastic.
Yeah. Yeah. Plastica. Yep. I do.
Yeah, over at Runnels. So, there's Dr. Sharman Robinson, physical therapist. Let me put that up there. There we go. All right. She says motion is lotion. Okay.
That's right.
There
That's
we
excellent.
go.
Great point.
There we go. All right. Let me go back to Jasmine. So, So Jasmine, every time she's always going to relate something back to massage therapy every episode. So,
No,
uh,
man, I think that's great. I mean, I think that's definitely anything we can do. The big drive is now is to do things that aren't narcotic wise for pain relief, right? And I think physical therapy, massage therapy, all those things are excellent. Pain relieving modalities, and so anything we can do to avoid having somebody on some kind of opioid, I think is great. And so I think massage is definitely an excellent tool to try to help pain relief, help motion. I mean, I think it's excellent.
awesome. That's one of the things I've tried to say my whole career, man. Even when I was in residency at UMC, and we had all this pain contract stuff, and then you had to do a urine drug screen, and you got to look at the PMP. I said, man, I don't want to do all this crap. I mean, look, let's just try to stay away from, like you said, narcotic.
Yeah.
They lead to nausea, sometimes even vomiting, abdominal pain, cramping,
Yeah.
depression,
I mean,
and
I think it's been shown that they're not effective long-term pain relieving modalities, right? I mean, people get on, they get used to the medicine, and they get higher and higher doses, and I just, people still, they're, I think I've seen plenty of people who've been on, were taking it, got off of it, like I don't feel any different than I did beforehand. I'm just not sick all the time from taking the opioids, So I think opioids definitely have their place, especially after surgery, those kind of things. We don't want the people to hurt because we want them to move. But I think long term, I think other things, physical therapy, massage therapy, all those things, just something else to try to help you is definitely way better than that for sure.
absolutely. I think we may need to get young Dr. Robinson here, the physical therapist. May need to get you guys in contact, man, and Jasmine. So, we get a whole network here, man. And so
Yeah,
they go to
yeah,
you for the surgery and
yeah.
physical therapy, and then we'll take care of the primary care,
That's right. That's right.
Um, all right. We've got another. What's going on? That's my family right there. That's my cousin Damon. What's going on? Let's see. Damon says, would you recommend heating pads to relieve lower back pain?
Yeah, I mean, I think that definitely has a place for sure. I mean, all those things, heat, ice, and I give people the same spiel. I don't think there's a great recommendation that ice is better than heat or heat's better than ice. I just think that whatever makes it feel better, right? I mean, heat increases the blood flow in an area, can definitely make pain, relaxes the muscles, which is muscle tension is definitely a main, big contributor to low back pain. So I think heat therapy is excellent. I think anything, like I said, that you can help outside of taking something, I think is good to try for sure.
Absolutely, absolutely. That's a great question. One of the things a lot of people, get mixed up on. They say, well, my doctor told me to alternate, heat and ice, and
Yeah.
so uh, and I've said that too. But do you feel? I mean, is that what you tell your patients to alternate, or is there one better than the other for
Oh man, I
chronic
mean,
aching pain?
I think that I think some things, if you have a lot of swelling, I think ice is better in those situations, because I think heat can exacerbate swelling, those kind of things. But if you're just aching, like muscle aches, those kind of things, I think heat is definitely reasonable. Um, a lot of times we'll do therapy, they'll ice you down and then kind of put some heat on there to kind of cool it off before you get done. So I think alternating those things is definitely reasonable. But some people don't tolerate ice. I mean, they think it hurts to put it on. So I think those people, heat is fine. I always tell people, anything you can do to try to help your symptoms, I think it's a reasonable approach. There's definitely not a downside to either one of those options.
Gotcha, gotcha. I'll pause for the calls real quick to do a quick shameless infomercial. So, ladies and gentlemen, this is Telehealth Tuesday. We're almost to the halfway mark. Dr. Baker, you're okay with going until about 8:15?
Sure, that's fine. Yeah,
I
that's
know
fine.
we started a little later. If that's okay. Okay. So we're about at the halfway mark, ladies and gentlemen. This is Telehealth Tuesday. We're here every Tuesday at 7 p.m. Central Standard Time with experts from all around the city, all around the state that are here, actually in out of state, to answer your questions. And I say out of state because we had my dear friend Glozell, who has over 5 million followers on YouTube.
Ooh,
She's in LA. She's interviewed everything from President Obama, Oprah Winfrey, and she's a comedian, but also a YouTube personality. So you can check out that episode. And we got Dr. Baker tonight, orthopedic surgeon. We've had Dr. North, plastic surgeon, Jasmine Briscoe, Sharman Robinson, physical therapy. Amazing. We've had OBGYN, a couple good friends of mine. So make sure not to miss a single episode. Everything's available on Dr. BTV on YouTube. And also, if you're here right now live, please make sure to give us your comments and questions, because it's not every day that you can ask the surgeon right here, ask your questions, whatever you need to know. So, all right. So back at it. Let's see. Jasmine is saying customize your self-care. Yep. Absolutely. Absolutely. So, let's talk. So would you say, I know we focus a lot more on the knees than hip. Do you do a little bit more knee surgeries than hip
yeah.
surgery?
So knee replacement's more common for sure. More common than hip replacement. So the most joint replacements, knees number one, followed by hip, and then kind of down the list from there. But
Okay.
knee is definitely more frequent. Like I said, probably. I mean, in my practice, I mean, probably 3 to 1, 2 to 1, more common. It's just a more commonly replaced joint.
Okay. Okay. Um, and do you feel like one is like maybe a more or less a complicated surgery, or?
I don't know. I mean, hip. I think so. Hip replacements do amazing. I think hip replacement is one of the best things that we have in orthopedics to do for somebody. Hips tend to always do well. They'll have some. It's very rare to have a person who had a hip replacement still have problems down the line, right? If it's done well, I think hip replacements it's really good. Therapy is not as hard as having your knee replacement. I tell people that having a knee is a hard operation to get over, because your knee has to bend, right? And
Mhm.
that's one of the big things you have to work on after surgery, is getting that knee to bend again, because it hurts. You don't want to bend it. I mean, it just it's definitely a more prolonged process. Hip doesn't move that much, right? So once you get the hip in there, they tend to do very well. So I think it's very rewarding, and then almost all those people are happy. There are some knee replacements. Most, like, if you look at percentage wise, most knee replacements do very well, but there's a percentage of people, 5, sometimes 10% of people in some studies, that just aren't happy. They have a well done knee replacement. You look at their images, they look good. They're not infected. Everything looks like you'd want it to look, and they're still, they still have some pain. They're not, they're not happy. And so I think that can be frustrating for you and for the patient, right? I mean, obviously you want to do a knee replacement on somebody, you want them to, want them to do well and be, happy they had it done. But that's not, it's not 100%. Hip is, it's real close.
Awesome. All right, let's see who's next. And my good friend, shout out to Remy J. Knott and Entertain Jackson, and also Jackson Foodies Group. Now he's an interesting guy. I've known him for a long time, and he's the proprietor, the owner of those groups, and they've got thousands of people all over the city and state. Man, all these foodies and
Yeah.
entertainment folks, man. And so he's a singer himself. Uh, so Remy says, are rotator cuff issues pretty common? And when do you know if you need surgery?
Yeah, so rotator cuff is extremely common. Rotator cuff is obviously it's a muscle in the shoulder, right? So your rotator cuff muscle back here, it makes a tendon. The tendon is what attaches the muscle to the bone, right? So when people say the rotator cuff, they're talking about the tendon that attaches to your shoulder, right? And that helps you kind of elevate your arm. And if you look at, they did some pretty good studies. Anybody over 50, they just did MRIs of people who didn't have any problems, right? 25 to 30% of those people had rotator cuff tears that didn't bother them, right? So it's really, really, really common problem. And so I think, again, one of those things, it just depends on how bad it bothers you. If it's something that you can't do the things you want to do because it hurts, then I think it's definitely reasonable to get fixed. And now, younger people, I think it's a little different, right? If you have an injury and you tear your rotator cuff, that almost always needs to be fixed. Because one thing we know about rotator cuff tears is if you don't fix them, they don't heal, right? And so an acute almost always needs surgery, especially in a younger person. Somebody in their 30s, 40s has an injury, tears their cuff. We know that long term they do better if their cuff is intact, right? So we almost always fix those people. But most of the people that come see us are older and they have, an overuse problem, right? So they've been, working in the yard, working in the house, they just, repetitive activity, they get, more of a chronic rotator cuff tear. And those people can sometimes be treated conservatively. Okay. I mean, we do same thing we do with arthritis. We do, anti-inflammatories, physical therapy, sometimes some injections. And a lot of those people have more chronic tears can be treated without having to operate on. And I tell people, if you tried those things, you're still not better, then I think rotator cuff surgery at that point is definitely reasonable.
Okay, awesome. Appreciate the question, Remy. Ebony Taylor, she's a good friend of mine and is a nurse. I'm sure well, I don't know if you worked with him, Ebony, but she says, when are you coming to Baptist, Dr. Baker?
Well, there was some talk I might do that at one point, but I think that is kind of fallen by the wayside. I can't do it.
You put the man on the spot on my show, Ebony.
Yeah. Yeah, there was some talk at one time I might make that move, but I think my current working situation is probably prohibitive of me doing that. So
it sounds like you're going to keep your talents, as LeBron said, where they are.
yeah.
All right, let's see. We've got Dr. Sharman Robinson, physical therapist. Thank you for your time, Dr. Baker. So I treat a lot of patellofemoral pain. Most of them resolve with physical therapy, but what are the other effective interventions for this global diagnosis besides PT and medicine? I know it's case by case basis.
Yeah, I mean, I think patellofemoral pain is incredibly common, and so sometimes we don't have a good reason. I think especially in younger females, that can be it's a really common problem that you just don't have a good answer for, right? I think honestly, I mean, he's right. The mainstay of treatment for that is physical therapy and anti-inflammatories. Depending on what the underlying cause is, sometimes they require some surgery, but most commonly, almost always can be treated with physical therapy and some kind of anti-inflammatory. Now, if people have an instability where their patella wants to come out of place, sometimes if that is refractory to physical therapy, you can do some things to stabilize their patella. And then, another thing, people can get, older people, patellofemoral pain from patellofemoral arthritis, right? So, we talked about that you have bone-on-bone arthritis in the weight-bearing parts of your knee, okay, between your shin bone and your thigh bone. But also, you can get isolated arthritis right behind your kneecap or your patella, and you can do isolated patellofemoral replacements for those people. But same kind of thing, anti-inflammatories, injections, all that stuff can be helpful.
Awesome, excellent questions, y'all. You guys, hey, keep them coming. This is why we're here. So keep these great questions coming. One of the things I know that back when I was in med school and probably up until first year in residency, which is years ago now, but one of the most common reasons, well, the most common reason or the most common complaint regarding pain was low back pain, the reason to visit the doctor. So when it comes to that, now, do you do any work on the spine at all?
I don't do any. I mean, I don't do any spine. No. I will see people with back pain, just because, like I said, doing general orthopedics, but I do not do any spine
Okay.
surgery for sure.
Okay. Okay. So when those patients come, the you will end up sending them to one of the spine specialists, or
Yeah,
you
I
know,
mean, I think if they need something, I mean, almost all back pain is muscular, kind of, in nature, right? I mean, a low back pain, arthritis in the facet joints of your back, those kind of things, and almost always that can be treated, without surgery, right? The main indication to have back surgery is if you have, a pinched nerve, right? That's surgery for that is good, right? Surgery for back pain in of itself is not doesn't do very well, right? I mean, so most of the time if they're having a back operation, it's because they're having ridiculous symptoms, which means, like I said, nerve pinch in their back that go into their either in their arm or their leg, and those people will need to see a spine surgeon. Um, but most people with low back pain, I mean, we treat them, just almost identically like we treat people with knee arthritis, right? Anti-inflammatories, physical therapy, all those kind of things, to kind of help them get better.
yeah, absolutely. Yeah, I know that we've had a lot of people that just really have been riddled with back. So because I'm thinking about all these patients, and even including my own mother, who's been, I mean, just suffering from this back pain, and like you said, ridiculous symptoms, pain radiating down the leg, hip pain, and even just terrible neuropathy, like you said,
Yep.
from the pinched nerve. Um, I mean, other than gabapentin and Lyrica, do you get into the weeds with that? Like, or you kind of stop it there when it comes to?
And I think I stop. I mean, in my practice, I kind of stop it there and send it to somebody else. We get pain management guy for some kind of block, or or one of the spine surgery kind of things. So.
Gotcha, gotcha. Man, you let's see here. I think did we get another one coming in? I thought we had. Okay, that's Sean Miles. So so what would you say is the healing time for a knee versus a hip? The recovery time.
Well, I mean, I think hips get better faster, like I said, because they don't have therapy's not as bad, right? They doesn't have to move as much. But statistically, if you look at both groups, I tell people it takes about a year to completely recover, right, from having your knee replaced. Especially if you look at how people do with time, they tend to continue to improve for about the first year, and even between year 1 and 2, people tend to get better. Most of that improvement is in the first 6 months or so, but it takes about a year for your knee to be what it is, right? I usually tell people that you got to give it a year to be to say it didn't help me, right? I've seen people come in there 6, 7 months out, still have a lot of pain. They come in at the year mark and they're like, man, I'm better. And so I think it definitely takes some recovery um, to get over that operation.
Gotcha. And when it comes to the knees and hips, like how much walking can a person do, post operatively?
Oh man, I mean, as much as they want to, the
Yeah,
more you move, the better. I think that moving is definitely key to getting over that operation, and so we want people to be able to be moving. I mean, you can overdo it, but I mean, I want every day you need to be walking.
gotcha. And do they need to be careful about how they walk around and how much weight they're bearing on the joint or anything?
Almost all the time, you can be weight bearing as tolerated, which means you can put as much weight on it as you want to. Now, sometimes there's some situations where we want people to kind of not put all their weight on it at first, but I'd say 95% of the time you can be fully weight bearing immediately. So
Okay. And let's say if somebody's either an athlete or even if they're an older patient that just is very active and works out, can you like jog on that knee or that hip? Can you do that?
I mean, people go back to playing tennis, people go back to snow skiing, all kinds of things. I mean, if people are doing it if people were able to do it before they had their operation, I think most people can get back to those kind of things after they have it done.
Yeah, that's awesome. Because I was thinking, I remember one time um, at a particular hospital here in Flowood, that a particular orthopedic surgeon who's very good. He specializes in knees and hips, and I remember taking care of this patient, and he did after the total. It was a partial knee or a total knee, but either way, like you said, he wanted the guy weight bearing as tolerated. And the guy was probably about 70 years old. And
Yeah,
this guy, man, was just doing laps around, I mean, like post op.
yeah,
And then the surgeon came back and saw him again and was like, you can go home. Like it was like 10 o'clock at night.
yeah. Yeah, no, I mean, I think especially now with the with the paint, we do. Everybody that I operate on at hospital I use, they get a block beforehand, some kind of nerve block by the anesthesiologist. And I mean, people, I mean, I think people hurt less than they used to. I mean, we didn't used to do all those kind of things, and now with regional anesthetics, I mean, people are up moving pretty good. I mean, there are a ton of hip and knee replacements that get done the same day, right? I mean, you have surgery that day, you go home, they get done at outpatient surgery centers. So I mean, it's just back when I first started, I mean, people would stay in the hospital for 2 or 3 days, and they would go
Right,
to
right.
rehab. I mean, it's just incredibly uncommon for that to happen now. I mean, almost every I tend to keep where I operate. Almost all of them stay overnight for an observation, go the next day. But it's incredibly uncommon for somebody to stay more than one night for me. And the other guys in town, I mean, almost all theirs. I know a couple of surgeons, all they'll do is an outpatient one, right? So I mean, if they have to do it in the hospital, they send them to some of their partners. But they got to do them all outpatient. So.
Wow, man. Okay. Uh, all right. Mom has a question. After knee surgery, are people able to be in their knee? I don't. You're saying in their needs and use their knee as they did before they had a knee problem. It's a baseline.
I mean, people should expect to do things that they used to could not do with less pain. I mean, that's the indication for having a knee replacement, right? So, I mean, you should expect to be able to go do the things you were doing before that would hurt without the pain you were having before. So,
Hmm. Okay. Okay. Let's see. Good questions. Keep them coming now. Keep them coming. Uh, Jasmine, Dr. Baker makes recovery sound, I guess, smooth and easy. Great energy for people who are afraid of invasive operations like me.
yeah, I mean, I think it's I don't mean to make it not it's not we can't do anything like that that's pain free, right? I mean, you're going to have some pain afterwards, but I think like I said, the vast majority of people do well, and we do things to try to keep them from hurting after it happens, right? And I think that with the navigation, the robot we're using, I think makes things more precise. I think the blocks we do beforehand, and most people generally do well. And I think that and also I think your attitude. I mean, I think you got to have the more positive people. I mean, people who are like coming and saying like, "I know I'm going to do well." I think almost all those people do well.
Absolutely.
I think I like to tell people once you get to the place in your mind where I hurt bad enough to want to have this operation. I think when you get to that place in your mind, those people do well. I try not to talk anybody into having a knee replacement. I've seen plenty of people that have bad knees that don't seem to me like they hurt bad enough to want to have it operated on. I think those people tend to be unhappier. I think those people are not as happy as the ones who, really get it, kind of get into their mind that I need to do this. And I think almost all those people are happy.
Wow. Man. So you basically saying kind of mind over matter kind of thing there.
Yeah, I mean, I think it definitely helps. I mean, I think that's just my personality, but I try to be positive. I mean, I think the more you're like, "Hey, man, you're doing great, you're doing good," I think that helps recovery for sure.
Yeah. Absolutely. Absolutely. Um, is there any, one of your patients that really kind of sticks out in your mind that, like, maybe like the first surgery you ever did on your own, or, some patient who has just been so miserable, and after you were able to operate on them, then, I mean, they were like your best friend, or they were like, man, Dr. Baker, I've never had a day being pain free. Like, is there any kind of story you want to share with us, or anything that sticks out in your mind?
I mean, I think probably one of the best ones. I had a guy who had something called avascular necrosis, right? So
Hmm.
people don't have, osteoarthritis or wear and tear. People get something called avascular necrosis, where I like to tell people it's kind of like the head of your femur, your hip bone, has a heart attack, right? Blood supply gets dead to it, and the bone dies. Okay, and I had a guy who was in his 30s who unfortunately had this happen to him, and I mean, he couldn't. He was used crutches every day. He couldn't work because he had this done, and I mean, we did a hip replacement on him, and I mean, he
This
was.
sickle cell patient.
Yep. Uh, no, he was not. That can be common. This guy though, not sickle cell. He had. I mean, I don't. We couldn't figure out what is it. He just
Mm.
had one hip. weren't sure why it happened to him, but I mean, he had bad avascular necrosis and just a terrible hip. And I mean, he was. I mean, it's almost like his joint was fused. I mean, his hip didn't move at all. He was using crutches to get around all the time. Couldn't work anymore. And I mean, we did hip replacement on that guy. And I mean, 6 months later, he's back. Working, not using anything, feels great. I mean, that's one of the
Wow,
most rewarding ones I've done recently. Yeah. So,
man, that's amazing.
yeah.
He's back to work and everything, and
Oh, yeah, dude. I mean, he was. I mean,
man,
I saw him the other day. He was almost 3 years out. He's doing great.
damn,
I think it's just one of those things, and that especially those people who are have something, and you know they're really keeping them from doing what they want to do. And I mean, I think given that I think that's rewarding about what I do is I think, letting people get back to be active, back to doing the things they want to do, playing with their grandkids again, walking again, going through it's just amazing how many people man, I can't go through the grocery store because my knee or my hip hurts so bad. And I think, when they come back and see you like, ah, man, I can walk around the grocery store. I don't, I think that's just,
That's,
definitely
that's
good.
amazing. Let's see. We've got several question comments that have come in. Let's see. Damon says, do females tend to have more hip problems than males? And if so, why? Interesting question.
I don't know what the data is on that. In my experience, I mean, I think it's pretty equal. And just think about patients I do in general. I guess is there some question that maybe childbearing is worse on your hip? But I just don't really see that. I don't necessarily see that in practice.
Hmm. Okay. Okay. Yeah, interesting question. Let's see here. Uh, Mom says, for example, can they? Oh, I think this might have been piggybacking on it. Can people bend their knees after surgery?
Yeah, I mean, for sure. So, if you look at, honestly, the greatest predictor of somebody's postoperative knee motion is their knee motion beforehand, right? So, people who are really stiff beforehand may be a little stiffer afterwards. But I mean, most people get 120 degrees of flexion, 120 to 130 degrees of flexion is what we'd like them to have.
Okay.
But as long as they get to 90 degrees of flexion, which is like kind of like a right angle. If you get to 90 degrees of flexion, you can do the things that people want to do, right? You can sit in your car, you can sit in the pew at church, you can go up and downstairs, those kind of things. But most people get 120 plus motion. So.
Awesome. Let's see. Jasmine, happy healing is very important.
I think it definitely helps for sure.
That's right. All right, let's see. Sharman Robinson, the physical therapist, she says, I've seen great outcomes with patients who complete a joint class prior to surgery. What's your take on this joint class? And from what I've seen, patient education exponentially increases functional outcomes and therapy compliance post-op.
Oh yeah, I mean, I think those are great, man. I think it gets the patient in and they know what to expect, right? I mean, I think you can tell them in the office, hey, this is what's going to happen, and this is what you're going to do afterwards. And I think in our interaction with them, patients don't tend to remember a lot about what you tell them, right? I mean,
Mhm.
no matter how many times we tell them something, write it down, give them something, they just don't remember much of what we tell them. And I think when they go to those pre-classes, they're very intensive and they kind of tell them exactly what's going to happen afterwards. They get them their equipment, they get them used to using their equipment, their walker, all those kind of things after they're going to have after surgery. And I think that definitely helps for sure.
Awesome. Great questions, guys. Great questions and great comments. And I definitely believe that happy healing is very important. Um, I remember being a tech at this hospital for women and babies, man, 20 years ago, and back home in Orlando. And there was a surgeon who said that, as many of his patients that would be okay with him praying with them before surgery, he would do all that, he would kind of hold their hand and, until they were induced and went to sleep and kind of be there when they woke up. And it was like, and he was a good surgeon, of course, anyway, but, it's like that whole mind over matter and especially for folks, that do go to church and believe in a higher power.
Yeah.
It was like they tend to do better. Has that been your experience in your practice too?
Yeah, I think for sure. I mean, I think, like I said, I think the outlook you have is definitely important. I think faith is definitely something that is very helpful. I mean, I think if you have, your trust in the right places, I think that definitely helps you get better.
Yeah, absolutely. Absolutely. Let's see where we are on time. Got a few more minutes, guys. We've got about 10 more minutes, 10, 12 more minutes. So ask your questions now. Again, quick pause for the calls. We are live here, Telehealth Tuesday, as we are each and every Tuesday at 7 o'clock p.m. Central Standard Time. Tonight, our guest is Dr. Donald Baker, orthopedic surgeon here, orthopedic surgeon to the stars. And we are here live. We've had some great questions and great audience participation, great comments, questions. We're talking all about joint replacement, knees and hips and shoulder surgery and recovery time. And then unfortunately for those here in Mississippi that suffer from morbid obesity, being obese and overweight, having diabetes, how that kind of literally, well, I guess for lack of a better word, weighs on you and can cause complications even with your surgery. And so, um, that's something to really keep in mind. So with every one of your patients now, I guess if it's a fairly young person, pretty much fairly healthy, from what I remember, working with you directly, a lot of times you'll go ahead and just do your own. You don't necessarily have to kind of have them cleared by the hospitalist or a primary doctor.
I mean, no, I mean, if somebody's young and healthy, we don't, do that. Now, everybody now, I think that operated where I'm operating now, they go to, so they get seen by somebody preoperatively, right? So
Okay.
somebody, and if they think they need more work, that they'll do it. But as long as nobody's, had a heart attack, had a stroke, doesn't smoke, their diabetes is controlled. I mean, I don't think that they, we don't necessarily say, hey, you have to go see, we don't send everybody to cardiology beforehand and be like, oh, you need cardiac clearance because you're having surgery. I think that's probably unnecessary. But they do get seen by, one of the hospitalists or one of the nurse practitioners sees all those people in pre-op clinic. So,
Okay. Okay. You feel that they do it, just kind of, I mean, I know that's like a best practice, but you feel like that they do a little bit better too in general.
oh yeah, I mean, I think they definitely, and they find things we don't. I mean, we might ask somebody, hey, do you see a cardiologist? Oh no,
Yeah.
no, I don't have any heart problems. And they're like, well, I had a heart attack 2 years ago. Like,
Yeah. The four stints and
you're like, I don't see anybody. And you're like, well, you're taking these medicines. And I think, if we don't catch that, I think they're really good at catching that beforehand too. So, and we hate for people to get to the day, they're planning on having surgery, they've hadn't eaten, they get up there, they've told their family they're having surgery, they've done all the planning, and they get to the hospital and they're like, oh, we found this out, you can't have surgery. Their kids.
yeah.
And that's definitely something we want to avoid because that just makes people unhappy and it ruins their plans. And so, if you can catch those kind of things that would delay your surgery beforehand, I think that's incredibly important. So,
One man, there's a surgeon here, and I tell you, man, it was only the good Lord Himself, man, that spared me from going after this guy because this guy, man, used to be so mean when I was in residency. He's here in Jackson,
yeah,
general surgeon. That's all I'll say. But this guy got so mad that he was going to do. It was an abscess, a butt abscess,
yeah,
so buttock abscess, and he was so mad at the residents, and I was just a guy on call, and he was just like shouting at me and everything. He says, "Man, I come up here to the hospital, and I'm getting ready to do this butt abscess on my lunch break, and the patient has a belly full of food, and you guys are idiots. You don't know how to make somebody NPO before surgery." And I said, "Oh man, I wasn't even there, man. Come
yeah,
on."
yeah.
So anyway, but my question is, how often do you like run into that, like people who just ate breakfast on the morning of surgery?
You'd be surprised. I mean, I've had people, you tell them, you give them paperwork beforehand, you cannot eat anything after midnight, right? You're having surgery, you need to be there, so it's not anything. And they'll be sitting in the room in the pre-op drinking something. You're like, I mean, you can't do that. I mean, and I guess people don't understand why, I mean, if you put somebody to sleep who's had something in their stomach, they can aspirate, right? Those contents can come up into their mouth and go in their lungs. I mean, it can give you pneumonia, right? So that's, we don't like to, like you be NPO. So, I mean, if I definitely had people show up and you're like, I had a biscuit a minute ago. I wasn't supposed to do that. They're like, no, I don't know how many times I told you. It's I told you, my nurse told you, it's on your piece of paper. Don't eat anything. They told you in pre-op clinic don't eat anything, and like you can't have surgery today now.
Yeah. So yeah, so if they now what so let's say if they have them a little, they just started sipping their coffee, or they just, one of those little tiny little 8 ounce cokes, and they just drank half of it. So would you say that you proceed with the operation with them, but maybe not solid food, or
I'm pretty so it's liquids is obviously less time than solids, but I mean anesthesia, especially for an elective case, I mean they don't want those people to they don't want anybody to aspirate, right? So I mean I think even especially if it's now if it's an emergency or it has to get done, they'll do something
right?
like with your airway and have to do it. But I mean for an elective case, we'll delay it. I mean yeah, I mean if you had it doesn't matter what it is. I mean they'll push you. We'll push you back. Yeah.
Okay.
Usually that just means, if you were supposed to be first, you might be last instead of first. You have to wait a little while, make it happen.
Oh, okay. So yeah, so you're not necessarily delaying them another day. You can just push them to the end if you can.
Yeah. Yeah. I mean, yeah. I mean, if it's a liquid, we're talking about like 4 hours usually. So I mean, they say,
Yeah.
well, you're supposed to be first, but you're going to be, be later.
But the guy that ate the biscuit, too late for him.
Late for him, yeah. I mean, if you have to wait 8, 6 or 8 hours, you're like, well, I mean, we don't want to operate on any midnight, so you got to come back tomorrow.
Jeez. Let's see another question here. Mom says, is repeat surgery performed on people who don't have good outcomes after knee and hip surgery?
Yeah, so we're talking about, that's what like would be a revision, right? So definitely revisions happen, and so I think that, if revisions for a good, if you look at something and something doesn't look like it's done right, something looks like, the most commonly would be loosening, right? So like the implant we put in has come loose from the bone on having to go in and do that again. So revisions for loosening or for, something we know is wrong, right? You look at an X-ray, you say, hey, I know there's something wrong here. I can fix that. Those people tend to do pretty well, right? They don't do near as well as people do with primaries. Sometimes there are people, like we said earlier, who had knee replacement who just, still hurt for some reason we can't figure it out, right? Everything looks good. A revision to those people don't do very well. I mean, I think that's not, if you see something you can fix, I think a revision is definitely a reasonable option, and those people tend to do well. But, revisions in a setting where like, man, everything looks great, and like, I can't take it anymore. You have to operate on me again. That's just, I try to tell people, I mean, it's not like we can't do that. But it's hard for me to tell you it's going to be helpful, right? I don't, we don't like the situation to be like, oh, we did this. You come in and see me 6 months later, a year out, and you're still in the same situation. And I think that's, the likelihood of that happening is somebody who has a, pretty good looking X-ray and a pretty, normal laboratory data. I think that's it's hard to tell those people to have it done again. You're just hard to tell them that they're going to do better. So.
Absolutely. We're almost at the time. Let's take the last two questions. If you all are going to get these questions in, let's come on right now. Let's ask your questions, make your comments, because we are almost out of time. So, one of the other things I was thinking about, with these folks that are, morbidly obese, and we kind of keep harping on that because, this is our patient population here.
Sure. Yeah, definitely.
Yeah, absolutely. What are your thoughts on what was that? Glucosamine chondroitin and all of that,
Yeah, so I mean, I think that actually, for those, there are actually some data to support its use, right? So I think, I'm definitely, I recommend that all the time. We have handouts in the office that have it on the piece of paper we give to people, that if you're, something else you can try. It's the joint fluid that lubricates your joint. That's kind of what it's made up of. And so I think those are good supplements to try. There's very little side effect to trying that, right? So I give people the same spiel. I'm like, I would try it, see if it helps, right? I mean, take it for weeks and see if you feel better. And if you can't tell the difference, stop and see how you feel. If you think it's helpful, there's definitely no reason not to continue.
Absolutely. Absolutely. Damon says, let's see. I've heard, like you said, that weight and non-physical movement is key to knee and hip pain. Why is that?
Well, especially for arthritis, right? I mean, arthritic knees and hips tend to get stiff, right? And so the less you move them, the more stiff they get, right? And that's just kind of self-fulfilling prophecy. So getting those people moving is key to kind of helping them do better in the long term. And weight, I mean, you're just putting more stress across the joint, right? For every, for every pound you put on your body, it's more stress across that joint, makes it wear out quicker, just, increases your pain. And weight loss has been shown to help in hip and knee pain. So, I mean, I think that those two things are just really connected.
Absolutely. Let's see. Great questions. Great question. Rona Huey. Good evening. Good evening. I've been getting X-ray reports with osteophytes, and my patients complained of moderate to severe pain. What is the recommendation for this?
Yeah, I mean, I think, like we said, I think mainstay of treatment is some kind of anti-inflammatory, Tylenol, Advil, Levin, those kind of things. Physical therapy to get them moving, and just being active. I think is my first recommendation for all those people. And if those things aren't effective, I think physical therapy or some kind of intra-articular injection if it comes to that.
Let's see. The report today was on the cervical spine. The report today was on the cervical spine.
Yeah, I mean, I think cervical spine and joint, just like hip and knee. I think the same treatment recommendations I think apply.
Awesome. Let's see. How about one more question? One more question. We'll take the next one that comes in, folks. We'll take the next one that comes in. In the meantime, okay, let me see. Oh, Remy says, great show. Tell Dr. Baker I'll be seeing him for my injection next week.
Sounds good.
Yeah. We'll take one more question, but in the meantime, man, we'd love for you to. Uh, I'm sorry. Thank you. Thank you. That was my thought, but I wanted to make okay regarding the cervical.
Yeah.
Okay. Awesome. You know, before we have that last question, and I'd love to give you the floor like we do each and every week to just talk about. Of course, the audience has heard what you do, the services you offer, but maybe if you could, for all the people that might have joined later or going to watch the show on the archives, just let them know who you are, what services you offer, where they can find you, and if you're taking new patients or not.
Yeah. Oh, yeah. So again, Don Baker, I'm a general orthopedic surgeon. So we do, hip and knee replacements. We see people for pretty much every joint and bone problem. And I work for Merit Health Medical Group. So Merit Health, hospitals in Jackson. So I'm on their website. We definitely take new patients. I don't think there's insurance we don't take. Happy to see anybody.
Awesome. And in your office in Brandon,
We have an office in Brandon and we have one in Jackson. So
mm,
an office, out on 18 by the about kind of towards Brandon High School, the new one, and then in South Jackson at the Merit Health Central, our offices in the medical office building there. So,
awesome. Well, two more just rolled in. Let's take these real quick here. Let's see. Sharman Robinson, do do the rooster injections have better outcomes than steroid injections? Good question.
yeah, like I told earlier, I think that rooster comb has kind of fallen out of favor. The data for that is not great, right? I mean, if you look at rooster comb injections versus saline or regular salt water injections, they don't do very well. So that's not done as much as it used to be. They just hadn't held up very well to long term.
Let's see. Get back. And also, let's see. Jasmine Briscoe says, "Have you ever performed a knee projection reduction?"
I'm not sure I know what that is. Knee projection.
A knee projection reduction. You might have to give us fill us in there,
Yeah.
Jasmine. If let me see. I'm gonna go ahead and Google it. Knee
Projection.
projection reduction. Let's see where they got it. It says for. Uh, yeah, I'm not sure. Just saying a projection is used for to demonstrate alignment of the femur and tibia in the investigation of valgus or varus deformity. Yeah, I'm not really sure on that one, Jasmine. So you might want to maybe you can give us a little clarity on that. Let's jump to this question here. Mom says, "Is there any salvation?" Oh, okay. Wait, hold 1 second. Jasmine says, "Someone who
Knees. No,
smaller."
I've not done that one.
Okay. Is there any salvation by exercise for knees that are already bone on bone?
Yeah, I mean, like I said, exercise has been shown repeatedly to be effective, even in people who have bone on bone arthritis. So I think it's definitely worth trying for sure.
Awesome. Well, I think that'll do it here. I know we went a little over time. I really appreciate you all for sticking with us, man. Doc, I appreciate you, man.
Thanks for having me on. I appreciate it, man.
Yeah, thank you so much. And you can, if you, put it on your own social media, let your patients know they can catch this on our archives. If anybody who wants to see it, I can send you the link. And
Oh yeah, okay, cool. Thanks.
yeah, and they can come to any one of the, this is broadcast on Facebook, Instagram, LinkedIn, and YouTube simultaneously. But yeah, Dr. BTV, and they can catch the rest of that. So let me go ahead and put this up and get that ready. So yeah, man. Well, look, we really appreciate you. We've enjoyed you. I think the audience has really benefited from this. We had some great questions,
Yep.
and thank y'all for your participation. So we got to have you back on. I tell all the guests, man. I said, look, I'm gonna go ahead and volunteer you. Have you back.
Sounds good, man. I'd be happy to.
Awesome. Well, ladies and gentlemen, again, thank you for watching Telehealth Tuesday, another fantastic episode. As always, we truly love all of our audience participation each and every week. We are always here each and every Tuesday at 7 p.m. Central Standard Time. So we hope you'll join us next Tuesday at 7 p.m. We have a very special guest, and you'll just have to stay tuned to see who that is. So look, make sure to bring a friend with you, okay? We want you to come back, but don't just come back empty-handed. It's like going to church, bring somebody with you. And don't forget to click the subscribe button to Dr. B TV. Lastly, if you have a story, testimony, or someone you'd love for us to feature, if you want to see Dr. Baker on again, or you want to see somebody else, or you yourself want to come on and share what your expertise is with our guests, we would love to have you on. So place it in the comments or send us a DM. We'd love to see it. So God willing, we'll see you next Tuesday at 7 p.m. Central Standard Time. Dr. B TV, DOCTOR TV on YouTube and also Facebook, Instagram. This is the place where we treat and discuss mind, body, and soul. And remember, always remember, that true wealth begins with good health. See you next time. Hello, I'm Dr. Michael Bookhardt. Come join us at our newest clinic location at Good Faith Wellness Center. We provide compassionate health care for your entire family, from virtual visits to office appointments. We're committed to providing the best care. We accept all insurances, and we provide monthly wellness plans. Let's start your family journey to a healthier, happier life. Schedule your appointment today, and remember, true wealth begins with good health.